Good morning. I want to thank all of you who are present. I'm Alonzo Bell Jr. I'm the president of the Virginia Peninsula Chapter of 100 Black Men of America Incorporated. Honored to be here with you this morning. Our chapter is dedicated to the 4 for the Future pillars as is established by our national headquarters, and those pillars are mentoring, which is our core and primary focus, health and wellness, education, and economic empowerment. The Davis Health Fair is part of our commitment to promoting health and wellness throughout the community. Our past health and wellness initiatives have included prostate health screenings in a forum, a colon cancer webinar, a mental health awareness webinar, and a comprehensive community health forum. Riverside Health System has continued to partner with us in conducting these health and wellness forums, and we are pleased to announce that the Hampton Roads Community Action Program has also partnered with us in bringing this morning's Women's Health Forum to you. I hope that all participants get something that is of benefit to you from our panelists, our testing, and our vaccines. I'd like to start first by thanking our partners. First, Riverside Health System is led by CEO William B. Downey. Mr. Downey has been instrumental in providing the support necessary for us to carry out this and prior health forums. He and his wife, Carol, have continued to support the Virginia Peninsula Chapter of the 100 Black Men, for whom they have personally supported scholarships. Also, Mr. Downey's leadership has led Riverside Health System to endow a scholarship to provide annual support to our mentees. The Hampton Roads Community Action Program is our newest partner, and we are pleased with the association. HR CAP is led by CEO Ms. Edith White. Ms. White is former president and CEO of the Urban League of Hampton Roads, Inc., and has over 20 years of experience in senior management of several nonprofit organizations. She has a lifelong commitment to developing human potential and community involvement. And I would also like to introduce our panel discussion leader, Ms. Angela Futrell. Ms. Futrell, to my right, is the CEO of the Southeastern Virginia Health System, and she's also the longest tenured employee of Southeastern Virginia Health System with over 30 years of service. Hard to imagine since she's only 40 years old. She holds a Master's of Science in Nursing with a concentration in Leadership and Management from Western Governors University, a Bachelor of Science degree in Nursing from Old Dominion University, and she's a 2004 graduate of the Johnson & Johnson UCLA Healthcare Executive Program. A little about the Southeastern Virginia Health System. The Southeastern Virginia Health System has operated for more than 40 years and is the premier community-based healthcare initiative in Hampton Roads for the insured, uninsured, and underinsured. The Southeastern Virginia Health System operates 15 community health care centers throughout Hampton Roads. They provide primary care and dental services to individuals and families in addition to health education, nutrition counseling, case management, referrals to specialty care, medication assistance, and on-site testing. Their physicians are board certified and provide services in the areas of family practice, internal medicine, pediatrics, obstetrics, and gynecology. The Southeastern Virginia Health System services over 25,000 patients annually. Ms. Futrell is also a board member of the Hampton Roads Community Action Program. Ms. Futrell?
Thank you.
You're welcome.
Good morning, good morning. And yes, I'm just a baby. I started very, very young in my career. I'm so excited to be here this morning. Are you? I'm excited because this is the first in-person engagement I have had since the pandemic. That's right. Come on. Somebody clap. It is so wonderful to be out and be among people and have interaction and talk, even though we have our mask on our face. That's all right. You all have some beautiful eyes. And again, thank you this morning for joining us. I want to thank you for joining the Let's Talk About Women's Health Forum. And of course, as Mr. Bell said, we want to thank 100 Black Men. It's a wonderful, wonderful organization. My organization, myself, we've worked with them for over 20 years in providing their male cancer screenings at our Stony Brook site, and we've had a wonderful, wonderful relationship. We also want to thank Riverside Health System this morning. And the newest, yes. And the newest health partners, Hampton Roads Community Action Program, a wonderful program that provides multiple services from the young ones and the development of the minds and the bodies of our young children on into adults, and helping folks who have been incarcerated and reestablishing them in the community. So it's a wonderful, wonderful partnership that they've come together this morning. This is the first healthcare event co-sponsored by 100 Black men with a primary focus on women's health. So I'm excited about that this morning. So we have a panel of wonderful specialists here who have presentations that they have prepared for us, and I know you have questions for them, right? We're not going to be quiet, are we? It's a little chilly outside, but I know our hearts and minds are already warmed up. So we're going to have some questions for them. I have to say personally, it's like karma to be here this morning. When I graduated from undergrad school in nursing, I started at Riverside Hospital in the NICU. That was my first job. So thank you, Riverside Health System. And then I've worked with 100 Black men for many, many years, continue to work with them. And then I'm currently on the board of HR CAP. So it's really nice to see all this partnership and collaborative work going on. So I will not delay any longer. Our first speaker for this morning presenter is Miss Ashley J. Walker. Ms. Walker works as a certified nurse midwife at Riverside Partners in Women's Health at Oyster Point. After practicing as a labor and delivery nurse, she pursued midwifery with 3 goals: to provide education and support to women across the lifespan, to provide care to diverse women amid the national maternal health crisis, and to help women understand their own reproductive health. Her areas of focus include family planning, reproductive life planning, and unmedicated birth. A strong believer in shared decision-making, Ms. Walker supports the transparent discussion of all options and her patients' ability to make appropriate choices. I present to you Ms. Walker.
Hi there, I'm Ashley. I am a certified nurse midwife with Partners in Women's Health. Our offices are in Newport News, Hampton, Williamsburg, and Gloucester. Currently, I'm at the Hampton office down in Mercury West, so come see me if you need women's health care. So I'll be presenting on what is prenatal care today. So prenatal care is medical care that you can get during your pregnancy. So pregnancy in general is considered to be 39 to 40 weeks long. 9 months or 3 trimesters that are divided into 13 to 14-week trimesters. Ideally, we encourage all women to get prenatal care in their first trimester, and it's as soon as you know that you're pregnant. The first trimester of pregnancy is the best time to date a pregnancy. There's more genetic screening options if the patient so desires. And there's also more opportunities to educate on limiting exposures to toxins, medications, safe environments to be working in, and things to focus on early in pregnancy to help limit exposure to your fetus. So the benefits of getting early prenatal care and prenatal care in general is that there's a lower risk of preterm birth in women who get regular prenatal care, better pregnancy outcomes, so lower pregnancy complications, reduce the risk factors for the fetus, and educate on safe medications, foods, and things like that while you're pregnant. There are several different options about who you can choose as your prenatal care provider. There's obstetricians, there's family practice doctors, there's certified nurse midwives like myself. There's also family nurse practitioners and women's health nurse practitioners who all provide prenatal care. Now, things to consider when choosing a provider for your prenatal care is, would you prefer a male versus a female provider? I think everyone should be encouraged to find someone who is licensed and board certified to provide their care. Do you take my insurance so that it's affordable to you? You should be looking for recommendations from families and friends and about whether they're reputable in the community and if they have safe outcomes. You should be looking for a location that's easy, with good hours that works for you to limit barriers to you not making it to your appointments. And then also things to think about as well is about whether you'd rather work with a group practice or a private doctor. With Riverside, most of our practices are group practices. So I myself am of a practice of obstetricians, gynecologists, midwives, nurse practitioners. In the hospital, it's the midwives and the OBGYNs. So you have to kind of consider what you would like to see there when you go to the hospital someday. And then what hospital will you deliver at? Ideally, every woman should be getting care with a provider who delivers at a specific hospital. So if you're coming to Riverside Women's Health, whether you're coming to Partners Women's Health or Brentwood, we all deliver at Riverside Hospital. So you should go where we know you. So ideally, you won't go to other hospitals because we have all your care and everything in our systems. So what happens at your first visit for prenatal care? Your first visit for prenatal care is by far the longest one, usually about 40 minutes. The provider is going to ask a lot of questions about your health history, about your family health history, what medications are you taking at the time of pregnancy or right before becoming pregnant, and then what is your pregnancy history, meaning how many times have you been pregnant and what were the outcomes from those pregnancies. You'll also get a physical exam, so determining height and weight, blood pressure, a pap smear if needed. There's STD screening, vaccinations that are recommended for pregnancy, and help you establish your due date, whether it be by your last menstrual period or from an ultrasound. And we also will recommend what medications you might need to start depending on certain risk factors, recommend a prenatal vitamin for you, and any dietary changes that need to happen in early pregnancy. In later visits, they're a little bit shorter, but there's still good things that are happening. So we're going to be checking on your height, your weight every visit going forward, and your blood pressure as well. We're going to start listening to the baby's heartbeat between 10 and 12 weeks. We're going to measure your belly beginning at 20 weeks. So that's a very easy way to determine whether the pregnancy is growing appropriately, whether the baby's growing appropriately. We will also do an anatomy ultrasound at 20 weeks. There are several prenatal tests that happen throughout the entire span of the pregnancy at different times. Towards the end of pregnancies, there may be a pelvic exam if the patient so wishes or if there's indication for it. And there's also good education to be given on resources for learning how to take care of a baby, feeding behaviors for babies, whether you want to breastfeed or formula feed, things about labor and what to expect, and then also what to expect in the postpartum period. So until 28 weeks, every visit is about every 4 weeks, so monthly. And then from 28 to 36 weeks, the visits become every 2 weeks. And then 36 weeks, we see the patient every single week until they deliver. I put a little note in here about weight gain for pregnancy, because it's usually what most women are concerned with at the very first visit. So weight gain in pregnancy is determined on how much you weighed before you were pregnant and your BMI. So if a patient was at a healthy weight before becoming pregnant, they would be expected to gain about 25 to 35 pounds. If they were underweight, 28 to 40 pounds. If they were overweight, they would be gaining 15 to 25 pounds. And if they were classified as obese, they'd be gaining 11 to 20 pounds. And this is all a little bit variable, especially if you're carrying multiples. We'd expect a little bit more weight gain in those circumstances. Ideally, you'll gain about 1 to 4 pounds in the first few months of pregnancy. Before 20 weeks is really not the time to start gaining weight because the baby does not have weight mostly until 20 weeks. Even at the 20-week ultrasound, babies typically are only about a pound. And then the second half of pregnancy, every woman should be gaining about half a pound to a pound a week. So everyone has to gain some weight while they're pregnant because gaining weight helps in different ways throughout your body. You're going to gain weight in the breast to assist with breastfeeding. That's about 1 to 3 pounds. The uterus is getting thicker and heavier. That's going to gain about 2 pounds. The placenta itself weighs about 1.5 pounds, and then there's about 2 pounds of fluid around the baby, and then actual weight of the baby. So the baby might weigh 7 to 8 pounds. That's how we come up with the, at minimum, nearly 20-pound weight gain. So things we caution patients about is that with excessive weight gain in pregnancy, there's an increased risk of C-section, increased risk of growing a large for gestational age fetus, which can have some complications when it comes time to deliver with things like shoulder dystocia, which is where the baby gets trapped on the way out, or the patient might also experience issues with increased weight retention after pregnancy. So that's why we try to give good counseling about gaining weight, but in a controlled way during pregnancy. So there are several different prenatal tests, like I mentioned earlier, during pregnancy. These tests are ways for us to know or find out how the baby is doing from the inside. Things that we might recommend would be carrier screening, which is determining you and your partner's genetic risk for passing on certain genes like cystic fibrosis, sickle cell anemia, spinal muscular atrophy. Those are the ones we recommend. So it's kind of outside of pregnancy, but still important. There's non-invasive pregnancy testing, which tests for Down syndrome and a variety of other syndromes associated with negative outcomes for some fetuses. That's offered after 10 weeks. It also can determine the gender. There's a quad screen, which determines also risk for Down syndrome and for spina bifida. There are glucose screening tests and a complete blood count. We also do that to check for anemia and for gestational diabetes. And then at the end of pregnancy, there's a group B strep test that we test every mom for to see if they carry a certain bacteria that can be harmful to the baby. And then lastly, I put a little bit of a note about childbirth education. Childbirth education is separate from prenatal care, and I recommend every woman, especially a first-time mother, to obtain childbirth education prior to delivering. So this is education that can help you understand the labor process and what to expect. Examples would be things like Lamaze, the Bradley method, Alexander. Riverside also offers its own childbirth education courses that I recommend for every patient so that we can kind of manage expectations about what to expect for the length of labor, what kind of medications you'd like to use, if any, in labor, what to expect with delivery and pushing, and when the baby actually comes, learning about baby care, breastfeeding, and things like that. So there's plenty of benefits to getting some childbirth education prior. I really, personally, I feel very sad for when patients come in with no idea about what's going to happen, because when you do get it, you might experience increased confidence in your own ability to birth. You will have increased understanding of the signs of labor and the stages of labor. You can figure out your own birth preferences, whether it be what position you'd like to deliver in, what medications you'd like for your baby to receive or not receive. Do you want to breastfeed? Do you want to do skin to skin? Things like that can be determined early. And then also how to take care of yourself postpartum and how to take care of your baby. So that was my presentation. If I have any questions, I'll take them now, or I'm not sure if they wanted to wait to the end.
Please.
Okay.
Questions? So I'm going to start. There you go.
Mm-hmm.
The Lamaze is breathing technique, right?
Yes.
What is Bradley?
So the Bradley method is a method. This is mostly every woman, whether you're getting an epidural in labor or not, should have some kind of childbirth education. But the Bradley method is husband coached. So it's working with your partner, whoever's going to be there with you while you deliver, to help kind of, counsel and provide support during labor. It is still with breathing techniques, but that partner, the husband, typically speaks a lot for his wife when they're in pain. They help. You need someone who's really going to support you in a time where you're willing to say yes to anything or do whatever because you're in pain. The husband's there trying to provide that support to the patient by being kind of I don't want to call it a barrier, but being her spokesperson for her labor. It's a very intimate way of a husband and wife or a partner, boyfriend, girlfriend, or whoever, even, anybody who's going to be your support person, to really take on the responsibility of being your spokesperson while you're focusing on laboring. Yes.
Today, are nurses midwives going out into the homes at all? Is that an option?
With Riverside, all of the nurse midwives who work for Riverside deliver in hospital, but there are certified nurse midwives and certified midwives who deliver at home. Determining whether you'd like to deliver at home or deliver in a hospital is kind of a personal choice between the patient and then her support people and also the practitioner. Home birth is considered safe, but ideally you have to be prepared for if anything bad was to happen, where would you like to be when you deliver? So with Partners in Women's Health, we are all somewhat interchangeable in the office environment. I only say that for the fact that we encourage all of our patients to see all of our providers because you don't know who's going to be there when you labor. But we all kind of work together to keep running notes of all of our patients so we know what's going on at every visit. We all have practice guidelines and things that we are standardized to that we are essentially doing the same things. Seeing a midwife versus the obstetrician is not really necessarily much of a difference, except that every provider has their own little flavor about the education and things like that they'd like to provide a patient with during their visits. But ideally, like the medical care is the same.
Other questions?
All right.
Let's give Ms. Walker a hand. It's never easy being the first, and she did a wonderful job. Thank you so much. So we'll move right on to our next panelist, Dr. Barbara Ellen Simpson. Dr. Simpson earned her medical degree from the Virginia Commonwealth University School of Medicine and completed an obstetrics and gynecology residency with VCU Health System. She is board certified by the American Board of Obstetrics and Gynecology and is a fellow of the American College of Obstetrics and Gynecology. With a women's health practice that includes a combination of low and high-risk obstetrics as well as gynecological care for teens through postmenopausal women, Dr. Simpson is experienced with a wide range of treatments, including management of abnormal pap smears, endometrial ablation, and laparoscopic hysterectomy. She had all the tongue twisters. I'm telling you. She enjoys counseling her patients and helping them to achieve their health goals both during pregnancy and beyond. Dr. Simpson had a commitment education as well as to women's health. As director of Riverside Regional Medical Center's OBGYN residency program, Dr. Simpson's mission is also to turn out well-rounded physicians that have mastered the most up-to-date medical and surgical treatments for straightforward or complex cases. Dr. Simpson will talk to us about women's health care this morning. Dr. Simpson?
Good morning. Thank you so much for having me here. I'm very honored to be here and speaking about women's health. This is obviously a passion of mine with what I do. And it's something that really struck a chord with me from an early age, although I guess I never really envisioned that I would eventually be an OBGYN. I kind of found my path and my passion as actually part of the community here. I actually worked for the fire department for 6.5 years, so really got to know the Hampton Roads community, and then found my path to medical school, and then discovered women's health and how I really enjoyed that connection with women and making care not only in pregnancy, but then of course so much of women's years are spent beyond outside of pregnancy, and really how that partnership can form that extends through a woman's life to enable her to make those decisions about her health and guide that journey together. Okay. So one of the biggest things I want to talk about is prevention today. There's so much that you can do to take charge of your health with all the wonderful folks that are here kind of touching on a number of topics and the tables that you'll be able to visit beyond these talks about education about your health and taking charge of it. For us, part of it is really the women's health exam. It's a great chance for you to come in and meet your OBGYN and kind of talk about your overall health, your health goals, your health concerns. We do advocate for that still as an annual visit, which is kind of why we got the name, even though some of the screenings are not necessarily done every year. It's our chance to really meet with you and get that information about your health, how you're doing, your well-being. And then from there, we make those decisions together and recommendations about what screenings we do need to go ahead and complete while you're there with your visit. We want to discuss your periods. So if you're still menstruating or if you're postmenopausal, if you're not, and then from there, finding anything that's a concern that we need to do some extra investigation of. We want to talk about, again, specific cancer screenings while we're trying to keep you healthy, and then also just, we're kind of your gateway as well. So some women only really make it to the OBGYN, so we can be your gateway as far as maybe other doctors or other areas that we need to address your health concerns. One of the things that really concerns me, we know we're just starting to get back to normal. This is, a first in-person event for a lot of people, because COVID really shut us down, and it shut us down on the medical side too. We were still there. Our office actually never closed. People were still having babies, but it really made a lot of us, worried to leave our homes or to come into contact with other people. So a lot of, patients in general, but women were not leaving and coming to get these screenings. So I was actually really surprised and worried about these statistics that I was able to find, that the screening rates in the U.S. just in this time frame, and this is just looking since April of 2020, decrease in 94% of women coming out to get their mammograms, decrease of 94% of people coming into the office to get their pap smears, and then even colorectal cancer, 86% for men and women coming in to get that very necessary screening. So with that, unfortunately, we are seeing some rises in cancers, because these are all cancers that are very preventable or very easily picked up in that early stage by these screenings, where we can really intervene and make a difference in your health. So I thought this was important to start talking about breast cancer prevention. It's a very common cancer. About 1 in 8 women can develop breast cancer over the course of their lifetime. That's 13% of our population. In 2020, we found an estimated 287,000 plus cases of invasive breast cancer. So just some, crazy numbers to put that in perspective as far as how much we see that cancer. And actually, it was thought to be, it's actually one of the most common cancers worldwide. And then in women specifically under 45, so think about young women. So we're just kind of at that early parts of our screening for breast cancer. Breast cancer is more common in Black women than white women at that age. Also, Black women are more likely to die of breast cancer. And then for Asian, Hispanic, Native American women, that risk of developing and dying from breast cancer is lower. And you can go ahead and, online, I wanted to give kudos out to breastcancer.org for providing some of those statistics. And they also have great information on that website as well. So we want women to come in for their screening. So part of what we'll do as an OBGYN at that annual exam is find out if you have any concerns about your breasts. You've got them all the time. So I want you to be aware of your body and notice if there's any changes, because those changes would be causes of concern that you then bring to our attention. And then we can do an exam of the breast and see if we do feel lumps, masses, skin changes that would be concerning. And then, of course, we're making sure that you go ahead and get your annual mammogram. So we do start that screening around age 40. Sometimes it's earlier, though. If you have a family history, a strong family history for breast cancer, especially if the women in your family have maybe developed breast cancer earlier than age 40, then we may want to actually start that screening even earlier. So again, it's all about that conversation that you're going to have with your OBGYN. And then we can start that screening at age 40 for the general population. And certainly by age 45, all of the cancer screening and United States Health Prevention Task Force all recommend really starting that mammogram screening for breast cancer. And then it's really up to you. So it's a decision that you make with your OBGYN, also according to your preferences, and then also your family history of beyond 55, if we're still doing that every year or start screening every other year. We still recommend that screening, though, well beyond age 55, as long as the woman's in good health, because again, breast cancer is something that we can pick up and intervene with very early. Next, I want to talk about cervical cancer. So cervical cancer, so some people don't always know kind of what the cervix is. The cervix is actually the opening part for the uterus. So we actually screen for cervical cancer by doing a pelvic exam. The 2022 kind of things, 14,000 cases of new cervical cancer will be diagnosed. And in that year, about 4,200 women will die from cervical cancer. So not as common as breast cancer, but it is still a very common cancer. And it's one that we can really intervene. We pick with the screenings, we pick up these precancer changes very, very early. And we can intervene before it actually has a big impact on the woman's health. And it's actually very simple in-office procedures that we can do to stop these early precancer changes before they have a chance to go on into real cancer or invasive cancer. Cervical cancer is most frequently diagnosed actually in young women, so between ages 35 to 44, but average diagnosis around age 50. And then it rarely develops in women younger than 20, extremely rare. And that's where we kind of get our cancer screening recommendations. Again, just looking at the missed opportunities for cervical cancer screening. Again, this is a test that can only be done by coming to see either an OBGYN, you can see your family practitioner. There's a lot of other specialists that are also able to do that pap smear test. The biggest thing is coming in and having that pap smear test done, getting that screening for cervical cancer. Because a lot of times when we see that invasive cervical cancer, it's in women that have missed those screenings, that have not been screened since maybe they delivered their children and maybe 10 years prior, and then have not made it to the doctor for that screening, and then they're coming back and they've got cancer. So we really want to reach all of those women in those in between times where they maybe feel, okay, my health is fine, I don't need to go to the doctor. There's not early symptoms when you have those cervical changes. Women don't tend to develop symptoms until truly they have cancer. So the way we prevent cancer, again, is with a very simple screening test, the pap smear. We recommend that we start looking at the pap smear at age 21. And one of the things that we're mindful of, and I'll talk a little bit more about, is the HPV virus. So it's human papilloma virus. That is actually a virus that has no symptoms typically to it. It is passed by sexual contact. There's a number of strains of this virus. This virus also, some of its strains can cause warts. But the specific strains that cause or are most related to cervical cancer do not have any other outward signs. People do not know that they have it. Men don't know that they have it and can pass it on to their female partners, and women don't know that they have it as well. So it's not until it's there on that cervix that it starts causing those changes that can lead down that pathway towards cervical cancer. So again, we recommend starting that screening with pap smears at age 21. And through age 21 to age 30, typically we're doing those pap smears every 3 years. Depending on if the pap smears come back as abnormal or concerning cells, then we're your guides to kind of mentor you and help have those discussions of what we need to do. And it's all risk-based as far as what our recommendations are. Sometimes we'll have to do biopsies. Sometimes we'll have to kind of shave off or remove a little portion of that cervix to help remove those precancer cells before they have a chance to go on towards cancer. Once you hit age 30, then we recommend a dual cancer screening approach. At that point, we screen not only the cells from the cervix, which is the pap smear, we also test specifically for those high-risk strains of the human papilloma virus. Because even if the cells are normal, having that virus there still conveys some cancer risk. So then we know to watch you more closely to help make sure that your body clears the virus. It is a virus. Your immune system can fight and get rid of this. It doesn't mean it's always going to be there. What we worry about is when that virus is there, the longer time it's there, the more chances it has to cause those changes to leads to the precancer cells that go on and lead to cervical cancer. So screening doesn't always have to go on forever. Again, the risk for cervical cancer is that HPV virus, which is, again, sexually transmitted. So once we get you to age 65, if you've never had any abnormal pap smears or it's been more than 20 years since any abnormal, then we can start discussing whether stopping that pap smear screening is the right choice for you. We still want you to be very conscious of your body. So even past age 65, there still potentially is a role for the pap smear, but otherwise there's still definitely a role to come in and see your OBGYN, just to again make sure that there's no other GYN concerns or problems going on. So I said I would talk a little bit more about HPV. So again, as we mentioned, it was a HPV virus. So it's actually tied to a number of cancers, not just cervical cancer. It also can be vulvar, vaginal, anal cancers. It can cause genital warts. And it does that as well in men. It can cause those cancers and also warts as well. And because of that, they actually have developed a vaccine against this virus. Over the years, the vaccine has expanded, and now it covers the 9 most common strains that cause these infections. And they've expanded, actually not only giving it just to women, but to giving it to men as well. And they start early because we want to get that protection out there before girls and boys are even ever exposed to it in a sexually transmitted fashion. So we start ages 9, and then all the way up through age 45, we can do this series of vaccines. So it's something that the pediatricians have in their office. So as parents, you might have already had some of that discussion with the pediatricians of whether that's the right choice for your child to go ahead and get this as a vaccine. We actually have it in our OBGYN office as well. So for those that hadn't received that earlier on, we can do that again all the way up through age 45. And we do recommend that vaccine because as the vaccine has been out well more than, 15, 20 years almost now of data, we have seen a really abrupt and very significant decrease in cervical cancer because of this vaccine. So the pap smear is still necessary, but we're fortunately finding that women that are protected, we're not seeing those pre-cancer changes. Some other reasons to come see your OBGYN is also to talk about birth control. So for women who don't want to expand their family at that time, there's lots of birth control options. And really, we need to see you and talk through your health history to see what the best choice is for you. There's so many options available, very short-term options that have been around a long time, like a pill, there's a patch, there's a vaginal ring. And then we advocate there's a lot of longer-term options that are good for 3 or even 5 or actually now even 7 years. So there's the Nexplanon, which is good for 3 years, that goes in the arm. There's the IUD, so intrauterine device. They get placed obviously at the doctor's office, and they're good depending on the hormonal amount that's in them for 3, 5, or even 7 years. And they also do some nice things as well for women that have problems with very heavy or very irregular bleeding. They actually can help with bleeding as well. There are still permanent options out there, so commonly the tubal ligation, which is considered a permanent female sterilization. So for women that are absolutely sure that they are done with all of their childbearing. And again, it's a shared decision-making process. We want to find what you feel the best option is for your body. We go through all the risks and benefits for all of those things to help you to find what seems like the best fit for you and the best fit in the stage of life that you're at. Some other reasons to come and see your OBGYN would be any other concerning problems. So if you have heavy menstrual bleeding, if you have bleeding between your periods, that would be concerning. Because that can sometimes be a hallmark that there's either an infection going on, or sometimes even it can be a hallmark that there might be some cancer or pre-cancer going on up inside the uterus. So we don't know kind of the cause until you come in and see us. And then we'll recommend a series of tests to investigate based on your symptoms what the best way is for us to diagnose this together and then manage it. Maybe you found that you had fibroids. We do very commonly see fibroids run in families. So some of our patients come in and didn't know that they had fibroids, but maybe have had very heavy periods, and we're able to find that together during an exam or during an ultrasound. And they go, oh yes, my mom, my sister, they've had to have hysterectomies because of their bleeding and their fibroids. So we do very commonly, again, find that runs in families. So it's important to know not only your own health, but also the health of your family. So your moms, your sisters, your aunts, and kind of what they've been through with their female health journey. If you have other symptoms like pain, if you have symptoms of abnormal vaginal discharge, things that you might be worried about for an infection, again, those are all reasons to come and see us, not just wait for your annual exam, but to come make an appointment to get those important testings and let us know what's going on so we can figure that out together. And again, with Riverside, we want to be a partner in your female health. So I'm actually at Brentwood, which is on Jefferson Avenue. With that location, I have faculty, so board certified OBGYNs that have been practicing for many years. And then we oversee the residency training program. So these are new OBGYNs. So they are doctors, but they're going through their 4 years of extensive training to learn all of the latest techniques and recommendations to guide patients when they're out on their own in the future. During the time that they're here with us at Riverside, they're all supervised very closely by a very experienced OBGYN to help guide as they're in that learning phase. The other thing I love with Brentwood is we're right across the hallway from family medicine. So again, I mentioned that we're sometimes that gateway into health. So as we're caring for women through their pregnancy, or as we're caring for women beyond outside of the pregnancy and seeing you for a problem or an annual exam, again, we have those partners across the hall that we can help get access to for any other health concerns. And then again, as Ashley is from Riverside Partners in Women's Health, they have several locations. So again, it's all about finding a doctor's office that's convenient for you, because we want you to come and get these screenings done. We want to be partners in taking care of your health and helping you with any of these concerns. And the only way we can do that is if we're getting you in so we can see you and address those things together. And that's all I've got. Thank you.
Questions?
Anybody have any questions right now? I think we're,
Dr. Simpson, we'll be glad to entertain any questions you might have.
yes, ma'am.
Earlier in your presentation, I believe the 45 and younger Black females said that they're more likely to die. Why is that? Is that because of lack of screening, or is there some other reason?
Just a moment, Doctor. Did everyone hear the question? Just wanted to make sure. I think there was a reference to Black women dying at an earlier age, 45 and younger, due to cervical cancer or breast cancer.
Breast cancer. And actually, a lot of that is a screening barrier, so that women are not always coming in for their screenings. Developing that trust and getting access to that care is certainly a component. And there's also a fairly large genetic component as well, that we are seeing breast cancer very commonly in Black women. So it's a twofold, unfortunately.
Then I have a follow-up. So I know in our community, sometimes we're not very trusting of the medical profession. So what do you say to the people in this room, including myself, to make us more comfortable and want to come in to get the various screenings that you discussed today?
Can you repeat the question?
She's asking me what I can do to reach out to the community, to women that are maybe nervous and don't have that trust in the medical profession. How do I spread that word to try to get women to trust and to come in and see us? And really, I want to get that out there, that as a woman, I want to hear your story. Everybody has their own pathway and a different way that they've gone through life and the experience that you maybe have had. I want to hear that story. I want to take that into account as we're talking through this, because it's a partnership, and I want to convey that you're in charge of your health. And my goal is to educate you about what the risks, the concerns are, what the recommendations are, so we can be a partner in this. So I want women to come in because we want to hear where you're coming from. We want to hear what your concerns are, what your family story has been, because all that factors into where you are at this point in your life. So I think the biggest thing to try to get women to come into screening is that it's not a one-size-fits-all. We have general recommendations, but as we want to be those partners, so we want to come in, and we can only do that by knowing that we want to hear what you have to say. We want to hear what your worries are, and then we want to go from there to provide that trusted care.
Okay, and I do have one final question.
Yes, ma'am.
So this is the PAP center. So for as long as I've known and had an annual exam, the standard was to get a PAP smear every year. Now, I was shocked this year, and this is what we're approaching, but I'll put it out there because maybe it'll be helpful to someone else. This year, I did receive the pelvic exam, but she said the PAP smear was not necessary, but I noticed in your presentation, you indicated that, well, that should happen at 65 and over. Well, I'm not 65, so there seems to be some discrepancy in terms of when you don't need to continue to have it on a yearly basis.
Actually, right from the start, we actually spread that screening out. So the more we've learned about cervical cancer, the more we know that those changes are very slow to happen. So from ages 21 to 30, if the pap smear is normal, we actually only do the pap smears every 3 years. We still want to see women in those in-between times to check on health status, see if they have other concerns. In that age range, a lot of women are maybe using birth control or considering either expanding their family. So we want to see women to help with those decision makings too. And then if they have any other health concerns, we would still potentially do an exam at that visit. And again, make that decision together about what needs to be done. But as long as the pap smear is normal, then it's every 3 years. The difference then goes on to age 30 and beyond when we expand that screening and we're testing for that human papilloma virus, which is that risk factor. We don't test earlier for that specifically because we assume any woman who is sexually active has potentially come in contact with that virus. That virus, again, is very, very slow to cause those changes. So we want to give those young women a chance for their immune system to clear the virus. By age 30, women should have cleared that virus. So we worry more if it is still there, that it's had that longer time frame to cause those changes that can lead to cervical cancer. So with that dual screening that we start, the recommendation for that is we can wait even up to 5 years between pap smears if both of those tests are normal. So if she is negative for any of those high-risk strains that are associated with cervical cancer and the cells themselves look normal. In between those times, again, we still want to see you because if you have some changes in bleeding, if you have some other symptoms that might make us worried that maybe something is changing with your health, then again, we'll do that pelvic exam. If we see anything concerning or something with your story has made us worried that maybe there is a change, then we might go ahead and do that test early and not wait that 5 years. But otherwise, if nothing else has changed, we still want to see you. But that testing is very, very reliable as far as that human papilloma virus, that HPV, being the main risk factor for development of cervical cancer. Yep.
Thank you, Dr.
Thank you.
Thank you. You all are absolutely wonderful. Not yet. I got to introduce you. One more question. Did I cut someone off? Oh, I'm so sorry. Go right ahead.
Concerning her question, if you had a hysterectomy, do you have to have that pap smear?
Did you hear the question? Okay. If you've had a hysterectomy, do you have to continue to have the pap smear, correct? Okay.
So if you have not had a significantly abnormal pap smear, then your screening would be done. So as long as your hysterectomy was not done for a pre-cancer reason, or that you had concerns for pre-cancer in that cervical screening leading up to your hysterectomy, once you've had the hysterectomy and they did a complete where they removed the cervix, then you're done with that screening. Yep, your risk is gone. Yay.
Thank you all. And our next presenter is so excited. She was ready to come, but we got to tell you about her. So our next presenter is Miss Cindy Williams. Miss Williams received her BS in pharmacy from Virginia Commonwealth University. She has completed the Executive Management Program for Pharmacy Leaders at the Wharton School and the Pharmacy Leadership Institute at Boston University. She currently serves as VP Chief Pharmacy Officer for Riverside Health System in Newport News, Virginia. In this role, Ms. Williams is responsible for oversight of pharmacy practice and medication management for the acute care and post-acute care facilities, as well as a 700-member medical group. Ms. Williams has served on numerous professional organizations. She's the recipient of several awards recognizing her leadership and achievements in pharmacy and is the past board member at large, House of Delegates member, and president of Virginia Society of Health Systems Pharmacists. She holds adjunct faculty positions at Virginia Commonwealth University and Hampton University School of Pharmacies, and has completed certification programs in diabetes management and medication therapy management. Ms. Williams will talk to us this morning about cancer prevention, detection, and treatment. Ms. Williams.
Thank you so much. And then the other hat I wear is the COVID vaccine queen. So if you've got any COVID vaccine questions after this, you may have seen me locally on TV talking about COVID vaccine, which has been my life the last couple of years. So as a pharmacist, a lot of the time that I spend is obviously, or my team spends, is on the treatment side of cancer. But I was asked today just to give a little bit of a broader overview around cancer because, as Dr. Simpson said, so much of cancer is actually preventable. And we certainly know what causes a number of the cancers, and we do have good screening. So today I'm going to focus primarily on women's cancers because it's, that's what we're here to talk about today is women's health. But a lot of the principles that I'll talk about and some of the risk factors that we can control also apply to cancers that would be in men. So what is cancer? Cancer happens when abnormal cells divide without control and they start to invade other tissues. And so I think many of you have heard about the staging for cancer, and typically in those early stages, which is why it's so important to get screened so that we catch cancer early, those cancer cells are typically only going to be found in whatever that source of the cancer is. So perhaps that could be the colon cancer. But as those cells divide, they may actually go to other organs in the body. And as we see that cancer spread to other organs, then the treatment of that cancer becomes more and more difficult. Again, why it is so important to get early screening for cancer. We also know that cancer is pretty prevalent. There's probably not a person in this room that I would guess has not been somehow in their life impacted by cancer. Me personally, my mother is a 10-year survivor of ovarian cancer, which is actually somewhat rare to live 10 years. She had a somewhat unique case. My husband, through early screening, has prostate cancer, stage 1. But because of early screening, he's doing quite well. And I've got a sister-in-law, and both of my mother and father-in-law all were survivors or are survivors of cancer. So we know that it is very common, but I think the other thing that is very encouraging is because of early screening and because of really advances in cancer treatment, and I'll talk a little bit about different kinds of cancer treatment, we've got more and more people that are living long-term as cancer survivors, and I'll talk a little bit about what that means. So who's at risk? I'd say we're all at risk of developing cancer. Again, it's very common, but we do know that the risk increases with age, and for a number of different reasons. And that we also know that 86% of the cancers are diagnosed in people that are greater than or equal to 50 years of age. And so as we get older, it is important that we continue to get those routine screenings, whether that's, the routine colonoscopies or some other type of colon cancer screening, whether it's continuing on, depending on your own personal history with getting mammography, with getting mammograms. It's really important that we keep those screenings up. And I'm going to talk about some of those screenings, but I think the other thing, and Dr. Simpson had alluded to this, we also all know our own bodies, and if we see changes that seem atypical for us, that it's important that we actually consult with our physicians and that we make sure that there isn't something going on, because while there is screening for many cancers, there's not for every cancer, and it may be that you see changes in your own personal situation that may be indications that there may be an underlying health issue. We've already talked about that many cancers are preventable, and certainly there are screenings for many of these, and the earlier that we can find this cancer, the easier it is to treat and the increased chance of survivorship. So I think we know some of the common cancers that we see in women. Breast is certainly the most prevalent, and I know Dr. Simpson's done a good job talking about that. But some of the other kinds of cancers that are common in women could be lung cancer, typically in those that have a history of smoking. Colorectal cancer is actually common in women. Endometrial cancer, cervical cancer, skin cancer, and ovarian cancer. We also know that there are some health disparities, and we've talked a little bit about that already. Is it because of just the lack of trust, perhaps, in healthcare, access to healthcare, and getting those screenings? But we know that despite having similar rates of breast cancer, Black and African American women are more likely than white women to die of the disease, and part of that is because of potentially later diagnosis, but as well some genetic factors in there. We also know that Hispanic, Latino, and Black African American women have a higher rate of cervical cancer. And so, again, it's important to get the message out there and to make sure that we're all taking care and doing the things that we can to prevent cancer, including getting those needed screenings. So what are some of the ways to prevent cancer? I mean, I think we all really know these, but I don't know. It's sometimes easier to know things than it is to practice things. Staying away from tobacco. I think we all know after decades of tobacco use that, tobacco does cause lung cancer as well as a lot of other chronic health conditions. We need to eat healthy and stay at a healthy weight. When you carry extra weight, that can increase your risk for certain types of cancers. We need to get moving and get some physical activity. I mean, I think COVID has been very difficult, in addition to putting off needed medical care. I think, it was a stressful time for all of us. I know me personally, I'm about 15 pounds higher in weight than I was 2 years ago because I'm a stress eater, and the last 2 years has been very stressful. So we need to make sure that we're eating healthy, getting activity. If you do drink alcohol, you need to do that in moderation. There were a lot of reports that are out during COVID that the rate of alcohol consumption went up significantly during that COVID. And again, I think it's because of a lot of stress that people were feeling about the pandemic and about their own personal situations. We need to protect our skin. I've had some minor skin cancers removed. I grew up in a time where we didn't have SPF 50. I was a lifeguard. There really was no protection. So I had a lot of exposure to sun when I was young. And as a result, I'm going to have probably, lifelong looking for skin cancers. And one of the things that I do every year, and I will be honest, I got a little bit away from this in COVID because of how busy I was with other healthcare things, but going twice a year to get a skin cancer screening from a dermatologist to make sure that there are no abnormal growths and that they can get those early and get those taken off. We've already talked about getting vaccinated if you're in the age range, or if you've got children or grandchildren that are in the age range for getting the HPV vaccine. Very important in protecting against not only the virus and some of the other things it causes, but certainly cervical cancer. And I think knowing your family history, and we'll talk a little bit about that later, but if you've got a history of cancer in your family, depending on the type of cancer, that's going to make you more likely to potentially have cancer yourself. And so knowing that family history, and, if you don't know, perhaps did your grandparents have cancer, knowing what those family relationships are, it's really important because that will help the physician and you make the best informed decisions about your care. And then have regular checkups. So again, a little bit about your family history. You may be at higher risk for cancer if you've got a family history of breast, ovarian, uterine, or colorectal. And there are some genetic tests that can be done now if you do have a strong family history, depending on what relative it is. That may make sense, depending, again, something to talk over with your healthcare provider. For example, because my mother is now an ovarian cancer survivor, I've had genetic testing for ovarian cancer. Just to know what my risk factor is. So certainly if you've got that strong family history, something to talk about with your individual provider, physician, to see if that is something that makes sense for you. So let's talk a little bit about early detection. And a few of these slides Dr. Simpson's already talked about, so I'll just breeze through those. I will tell you that we do have a table in the health fair after this that has some handouts and whatnot that you can take with you that talks about some of these early treatment or early detection types of modalities. So I encourage you to go in and talk to those individuals from our cancer services and get more information. So we've already talked about breast cancer, so I won't spend a lot of time on this, but I think, it is really important that we do get those routine, that you do your own personal screenings, but that you get in for that scheduled mammography. I'll tell you one sort of brief story, and this is actually a patient at Riverside that I had the opportunity to do have some conversations with about a year and a half ago. And here was an individual that was, had been very religious about getting her mammography screenings, and then COVID came and we were all in lockdown, and it was time for her to get a mammography. And she said, I just don't know. I don't know if I'm comfortable because of what's going on with COVID to actually go in and get my mammography this year. So she put it off for a few months. She finally said, I'm going to go ahead and go and get it. And boy, is she glad that she did, because when she went in that year, she actually, breast cancer was diagnosed. And so I think she looks back and said, what if I didn't go in? My treatment may have been that much more difficult. The cancer may have spread. As it was, the cancer was pretty contained. They were able to do surgery and then chemotherapy. And to my knowledge, she's doing well at this point. So there's a lot of reasons we can give, and I'm one of the same, to put off those screenings, but it's really critical that we keep up with those screenings. Lung cancer, again, smoking is that number one relationship with lung cancer, but there could be other environmental factors. There could be exposures to, other types of carcinogens. There is a screening for lung cancer. It's not really a routine screening, but it's called low-dose CT screening. It is a service that Riverside provides, and when used in the right population, can do a good job of that early diagnosis of lung cancer. It's really indicated only for individuals who are generally in good health and have no symptoms, but are at high risk because of their smoking history and age. So again, something to talk about with your physician if in fact this may describe your health status. Colorectal, we've already talked about the importance of getting colonoscopies. I know it's something none of us that are age 50 and older, look forward to, but it's something we need to do. If you do have a history of colorectal cancer in your family, those screenings may be more frequently than the general population. For example, my husband, his sister was diagnosed with metastatic colon cancer under the age of 50, which is fairly rare. So my husband goes in more frequently for his colonoscopies to make sure that if in fact, because of that family history, he's at higher risk, that we will catch it earlier when there's just a better chance for treatment and survival. Cervical cancer, I know we've already talked quite a bit about this, so I won't spend any additional time other than to say, make sure that you're getting those pap smears and the HPV testing on schedule. So I want to flip over and talk a little bit about cancer treatments, because I think, many of us, and for years, we think about, surgery, radiation, and chemotherapy. And those are certainly still some of the mainstays of cancer. And depending on your cancer type and depending on the stage of the cancer, you may often get multiple types of things. You could have surgery, then you might have radiation. You may have surgery, and then you may have chemotherapy. But I think one of the things that's changed quite a bit over the last decade or so are the number of medication therapies. And so whereas chemotherapy has been around for many, many years, and I know everybody is familiar, probably knows somebody that's had chemotherapy. And chemotherapy is when, it's a drug, typically, or for years, it used to be a drug that was administered intravenously, so you would have to go into a clinic. We're seeing more and more chemotherapy agents that are available orally. So you may actually have a tablet or a capsule option now that doesn't require you to go in and get an IV, or that may be used in conjunction with other chemotherapy and other agents. Chemotherapy targets those rapidly growing cancer cells. But we also know over time chemotherapy has had a lot of side effects because it can target other cells as well. The chemotherapies that are available today tend to be a lot more targeted and much more specific to the cancers being treated. So they are still a mainstay of therapy. But there's some other types of medication therapies that are also being used now, may be used in conjunction with chemotherapy, may be used as a single agent depending on the cancer in your situation. One of those is hormone therapy, where there are hormones that are used that are very specific to the cancer type. You see these used very commonly in breast cancer as well as in prostate cancer, because those are cancers where hormones are involved in the cancer process. There's also a newer type of therapy called immunotherapies. These types of therapies actually work with your own immune system to help your immune system fight cancer. And so again, they're often used in conjunction with other medications. And so it's not uncommon when you come in for cancer care and you come in for the medication side of cancer care that you may be getting 2 or 3 different types of medications in order to effectively treat your cancer. There's a body out there that looks at all of the research and publishes guidelines for how we treat cancer, depending on the individual situation of the patient. And at Riverside, we follow those guidelines, and it's a staged approach, but it will often include more than one therapy type. And then, of course, we know we've got radiation therapy for certain types of cancer. There could also be stem cell transplants. And then I think one of the more recent, you may have heard about what's called precision medicine, where the medication is very targeted or the approach is very targeted to the individual. We're seeing that in cancer care as well. It's called targeted therapy, where that therapy really is targeted to the cancer type and to the cell type in that individual. That type of treatment does typically take additional testing in order to identify what needs to happen. But again, we've gone much beyond just having chemotherapy as an option, and most patients will end up getting a combination of things when their cancer treatment plan is developed in conjunction with their physician. And then I wanted to just spend a couple of minutes talking about cancer survivorship because of all of the advancements in prevention, early detection, a lot better treatment than we had a couple of decades ago. We're seeing more and more people be long-term cancer survivors. I mean, I think my mom is a great example. She will hit her 10-year cancer-free in September. And so we've got folks that are really living beyond cancer. And when that happens, you know, there are things that need to go along with that. So I'll just use my mom as an example. You know, after she had surgery, then she had chemotherapy. She had very frequent touch points with her physician after that. And initially it was every 3 months. And then it went, you know, to every 4 months. And then it went to every 6 months. And now she's once a year with her cancer specialist. But it's really important, you know, we've made that journey, we've gotten through chemotherapy, cancer-free, but it's really important to understand what that survivorship means and what, you know, what is going to give you the best health go forward. And that may mean more frequent touch points with your physician to do examinations, to do blood work and whatnot. So again, after the chemotherapy, after the treatment is done, there's a process where the physician, the treatment team will sit down and determine what that survivorship plan is. We also know that there can be you know, side effects to some of the treatments, and part of that survivorship plan may be also talking about what those longer term side effect management may need to be as a result of the treatment that you've had. And this is just a summary again. I think when we look at really that care continuum with cancer, we really need to start off with thinking about in our own lives or in the lives of our families, what can we do on the prevention side? So whether that's, not smoking, having a reasonable alcohol intake, keeping a healthy weight, staying active, eating healthy, to the detection piece, making sure where there are screenings available, that we get those screenings on schedule so that we get that early diagnosis, and then on through the diagnosis, the treatment, and then survivorship. So that's really what I had today. I'll be happy to answer any questions that you might have. Yes, ma'am.
Is proton therapy the same as radiation therapy or target therapy? And can you say more about that?
So proton therapy, it is, and I will say I'm probably not the expert on that. There may be better experts in the room, but it is a type of radiation therapy. It does, depending on the cancer type, tend to be a little more targeted. But it would fall into sort of that radiation therapy class of treatments. You're welcome. Yes, sir.
I heard through an advertisement about pancreatic cancer being the number one, but it wasn't on your list of black people, pancreatic. I heard that was the board was killing them. What you had on the list.
Yes. So I went through primarily the women's health cancers. Pancreatic cancer isn't as prevalent as some of the other cancers, but the thing with pancreatic cancer is the survival rate is just not as high as some other cancers. It tends to be a very difficult cancer to treat, and as a result, it does have a higher death rate than some of the other cancers that may be easier to diagnose early because of screening. There's not really a screening for pancreatic cancer. It's typically when you start having symptoms, but it's also a very difficult cancer to treat. I think with all cancers, we're seeing advancements. I know several people that have, lived several years after pancreatic cancer treatment, but it is one of the more difficult cancers. And you're right, it has a very high death rate compared to some of the other cancers. You're welcome. Yes, ma'am.
Ovarian cancer falls into that same discussion?
And I may defer to Dr. Simpson somewhat on the ovarian cancer side. I'll tell you my own personal story, and I think, this with my mom. I think it depends on how early it's caught and whether it's stayed encapsulated or if it's become diffuse and actually invaded other organs. So with my mom's personal story, even though her tumor was quite large by the time that it was diagnosed, it had stayed pretty much encapsulated, meaning that, it hadn't really spread out to get onto other organs. And so she was very fortunate, and I think that's why, even though it was fairly far along when it was identified, that she responded well to treatment because the surgery was able to really get all of the cancer. The problem is when it gets diffuse and it's not encapsulated like that, the surgical intervention has a really difficult time of getting all of that cancer, and so it may be more difficult to treat. I don't know if there's anything else you want to add.
Yeah, unfortunately, one of the big things with ovarian cancer is there's no good screening test for it. There's a lot of investigation going on, so they're trying to see, are different hormonal tests helpful? Would screening with ultrasound be helpful? And so far, they have not found a good answer for that, unfortunately. And ovarian cancer with the location in the pelvis, by the time women have symptoms, generally it has spread far beyond the ovary, unfortunately. So when we are diagnosing these cancers, it's very rare for us to find a small and early cancer, like a stage 1 cancer, which has excellent survivorship in comparison. Most of the time when we're diagnosing ovarian cancer, it's stage 3 or stage 4. So much more difficult to treat because it's spread beyond the ovary. It kind of scatters throughout basically the inside abdominal cavity. So it's very difficult, if not impossible, to remove everything surgically because the cancer has spread so extensively.
And is it easily detected?
No, and unfortunately, the detection, even when you're having your annual exams and regular exams, with where the ovaries are located, sometimes we can feel them and sometimes we can detect a mass, but a lot of times we're not even really able to feel that in those early cancers because they're still encapsulated within the ovary. You can't feel them even on an exam. And again, there's no symptom to the woman at that point.
Yes, sir.
Years ago, many insurance companies
Yeah, so the question is insurance coverage for some of these higher level treatments. And I would say I think that continues to be a barrier to care for everybody, right? I think what you will find is that the insurance companies will readily obviously pay for the lower level therapies, but I think when you start getting into some of the more advanced therapies, what they often want to see is that, you've exhausted everything else first. And we know with cancer care, it's expensive, right? And there's a lot of financial toxicity that goes with that. I mean, at Riverside, we've got financial counselors that work with our patients to help make the best decisions, to look for, additional resources to help pay co-payments. And we, on the pharmacy side, we work with that every day with some of these medications. But I think you're right. There's still some barriers, not to say they may not pay for it, but usually you have to have jumped through a number of hoops first and tried other things before they may. And I know to the proton therapy we were talking about earlier, I think something, very similar is it's going to be dependent on the cancer type and whether they feel that, a lower cost treatment may be as effective before they'll pay for the higher cost. So I think the financial side continues to be a concern. Good question. Well, good. Well, thank you so much.
Thank you so much. And so, would you not say that our presenters thus far have done an excellent job? Yes? And so our last presenter, and most certainly as important as all of the other presentations that we've heard today, because we know that we should have a holistic approach in our healthcare. And so Ms. Halton, Ms. Cherie L. Halton, works as a utilization care manager at Riverside Behavioral Health, where she prepares patients for discharge planning, aftercare, and ensuring they have good support services in the community. She works with adolescents, teens, and adults. Ms. Halt has a bachelor's degree in healthcare administration from Ashford University with a history of personal care coordination for insurance holders with disabilities who need linkage for home care, as well as residential adolescent utilization insurance review work. She has a Master of Social Work degree from Damon University with a concentration in women and young adult social work. Ms. Halton's previous job included mental health counseling and running a community group for depression and women's empowerment. She is a member of the Postpartum Support Virginia Coalition, where she actively participates in learning, sharing, and improving the access to treatment for mothers who suffer from mental health diagnosis while pregnant, nursing, or postpartum. And again, to give us that holistic overview this morning, Ms. Halton will talk to us about women's mental health awareness. Ms. Halton.
Thank you very much. It's an honor and a privilege to be here. This is about our women, how important we are. It's also an honor and privilege to be a part of the Riverside Behavioral Health Hospital. Fortunately and unfortunately, by the time the women come through the doors of Riverside Behavioral Health in the psychiatric residential program, they have reached the end of their rope. They have succumbed to depression. They have succumbed to anxiety. They have reached the end of any type of help or assistance with the things that happen in the heart and the mind. They either didn't know how to reach for help. They come to the end of what they feel is any relief from the pressures and stress of life. And they come through our doors to receive a level of hope, care, a reprieve, counseling, medication, and just a light in their dark place. So today is very important that I'm able to talk about women and our mental health. So I'm very excited to be here today. Celebrating our she motions. Everyone say she motions. Yes, I do a lot of class participation. What are our she motions? So today, along with bringing awareness to mental health and how it affects us, I want to celebrate the wonderful beings that we are. We are women. We embody the earth. We have so many beautiful attributes to bring to the world, and our emotions are one of the main things that are before us. A lot of times we hear the cliche, oh, well, she's in her feelings, or you know how you women are. Yes, we are emotional creatures, but we are wonderful creatures. So along with awareness, I want to take this time to celebrate us in every nationality and walk of life that we have. So our emotions, they are what make up our mental health, our feelings, how we accept trauma, how we experience joy, how we reciprocate it, how we react from things of joy and things of sorrow. It's the mood. It's what makes us who we are. It makes things that make us smile, things that make us cry, things that make us concerned. Those are our she emotions. They are our mental health. Does mental health affect women differently than men? Yes or no? Absolutely. They do. The answer is yes. According to the World Health Organization, women are 2 times more likely than men to experience women's mental health problems, such as depression, eating disorders, and panic disorders. This is very true. Women, we are affected more than men when it comes to certain diagnoses, especially with depression. A lot of us don't know that we are depressed. It's very hard to detect. We think depression is just sadness. Depression does not have to necessarily just be sadness. You can go through your life and have everything you need and you want in your life and still have a level of hopelessness or a place where you've become complacent with what you don't have in the inside. And you can be depressed. You can be happy and have a lack of sleep. You can be happy and have racing thoughts going through your head, or lose joy and pleasure in doing things and still seem to have a complete life. There are many different facets of depression. Eating disorders happens a lot with our young women, with social media and how it affects what women should look like and what makes a woman look successful. In the adolescent and childhood of our young ladies, that's where the development starts, and the idea of who we are, sometimes it gets formed and presented to us in negative ways. So a lot of our eating disorders comes from our ability to want to look the part and to look presentable and to look what society deems as how to look perfect and how to look acceptable. Women, we feel these things more strongly than men. Panic disorders is also very important to know. It does occur more so in women than men. When we lose the ability to learn how to release worry, stress, and anxiety, and if we don't know how to process things such as trauma, childhood trauma, sexual trauma, we hold things a lot. We hold a lot of things in our mind and our hearts. Those can cause panic attacks, the inability to be able to maintain and get through negative flashbacks, feelings, or things that occur in our lives. Women, we are affected more than men in those areas. Women's serotonin levels are lower than men's. Why? Because they absorb the chemical faster, leading to mood swings. So these are some of the medical reasons how women are affected more than men. We absorb this chemical faster. Mood swings are real. I know women can attest to it. We have had a time where we are happy, full of joy, laughter, and in a moment, because of something that is said, something we remember, or a brush of the wind, our mood can change in an instant. A lot of this is because of this, our serotonin levels. Okay, they're lower. And when they're lower, they can't absorb as much. So it does affect women. Females are also more susceptible to hormone changes than males. This is very true to know. Our hormone changes we go through them a lot differently than men. We feel them a lot differently than men. And the changes sometimes happen more quickly than they are in men. Hormone changes are a big part of women and who we are. Post-traumatic stress disorder is more common in women than men. Did we know that? PTSD. It is. It's more common in women. Post-traumatic stress disorder. A single event, whether it happened one time or whether it happened over a moment in our childhood, something that happened in our adulthood, we saw something that affected us. We were a victim of rape, domestic violence, verbal abuse. We saw something happen to a family member or friend. We witnessed a murder. We served for our country. We have a high intense job. We survived domestic violence. We survived divorce. PTSD is very strong in women. We are affected by it more so than men. I wanted to touch before we went to this slide on the level of suicide. I didn't include this in my slide, but although the level of suicide attempts and suicide is stronger in men, the thoughts of suicide are stronger in women. So although we may not succeed in suicide, we think about it more. We have more suicidal ideations. We have more moments of helplessness and hopelessness where we don't want to be on this earth, thinking that that's the only way to relieve our pain. We have reached the end of our rope with what we think can help us. So suicide rates may be higher in men, but the suicidal thinking and things that lead us to think about suicide, those thoughts and that rate is higher in women. So there are a lot of variables and mental health diagnoses that affect women more than men. How gender roles may affect women's mental health. So in the slide, as you can see, there are gender roles that women have, and they do greatly affect women's mental health. So traditionally, back in the days, I don't want to say olden days, I don't want to offend anybody, we had gender roles. The women who were married were the homemakers. We stayed home, we cooked, cleaned, we tended to the home. If we had children, we tended to the children, we were caregivers. And a lot of times the men, the husbands, went out and they worked. They brought home the bacon, they brought home the bread, and we kept the home. So in a lot of ways, gender roles has affected our mental health. It is a job to be at home and raise children. It is a stressful job. It can be a stressful job. It is a rewarding job, and it's a privilege and a blessing to be a mother and to be a wife, but it comes with a lot of hard work, a lot of switching of the hands, so to speak. We multitask. We're the cookers. We clean. We're taxi drivers. We're burden bearers. We wipe tears. We give counsel to our children. We clean things. We keep things together. We have a lot of hats that we wear. And just like in those times, we are evolving in our gender roles. So a lot of women are not really staying at home as much anymore. Sometimes we are the homemakers and we go out and work. Women now are taking more roles that men used to take, as far as with jobs, with prestigious careers, or by chance, you can be one of the first African-American women to hold a Supreme Court justice. So the roles are changing. This is the world we live in. With those role changes, it comes a lot of mental health stability and instability factors. So as the roles may have changed, our mental health is greatly affected by these gender roles. I also have to touch on the fact that some of the homes of women, as far as our relationships, have also changed. So we have same-sex marriages. We have families that include moms, dads, grandparents. We are now caregivers of our loved ones, of the elderly. We may have 2 female homes with children. So with those gender changes, women are still affected by gender roles, whether you're same sex or not. We still have to pay very close attention to how mental health affects us with the everyday roles we do in life. How is my overall health affected by my mental health? Is my overall health affected by my mental health? Is the things I do each day, what I eat, who I'm with, what I experience, is that affected by my mental health? I know I need to take care of my outer health. I know I need to take care of, exercising and making sure I'm getting all the screenings I need for things such as cancer HPV, and I need to make sure if I'm pregnant, I have the right prenatal care. But what about my mental health? How is that affected? So mental health helps us maintain cognitive alternates, emotional sanity, and balance within ourselves, our lives, and our relationships. Yes, mental health helps in those actual areas. Emotional sanity always reaches to me because my everyday life and what I do and what I take on, it affects me emotionally. My emotions are affected by everything that I do, and my body and my physical body medically is also affected by my emotions. When you're in a bad mood on your menstrual, have hormone changes due to age changes, this all affects your mental health. Have you ever had a bad day where you don't even realize how you even got to the mood that you were in because it was so different from the mood you were in before? I'm happy, I'm getting my day started. Something is said or something is done, and my whole mood just changes. I'm not even hungry like I was before. I lost my appetite. Or I need to just go home, get a bucket of ice cream, sit in a corner with a blanket, and just watch a movie that's mushy. Our emotions are affected by everything that we do, and how our body reacts to it is important. So emotional sanity is very important to take close heed to. High blood pressure and elevated levels of stress hormones and adrenaline, which increase the heart rate. Yes, when I'm stressed out, my heart is pumping more. I feel more adrenaline. Sometimes if I get stressed, if I'm doing 15 different things, it affects my heart rate. It affects how the blood flows. And that does affect us medically. We can be in a very high stressful job, or things at home could be very stressful, especially if we're caregivers. And if we're in a relationship or married, and all those different switching of the hats that women do, that affects our levels, our stress hormones, how we can manage. And stress isn't always a bad thing. You could have exciting things happening in your life, and that's still considered stress. I call it happy stress. You're getting ready to plan for a trip, you're excited, you got your girlfriends coming in town, you got your in-laws coming. I don't know if that's good or bad stress, but stress is not always bad, and I'm trying to help bring awareness to the fact that stress is not always a negative thing, but we still need to be mindful of how good and bad stress affects the body. Stress affects our she-motions. So as you can see, we can be moms, mothers. If you don't have children, you can be caregivers of children. Your kid can have a temper tantrum one moment, and the next moment you're having a beautiful song that you're singing to one another, and you're enjoying the moments that you have with your children. But in an instant, their emotions affect our emotions. So all of our mothers and caregivers, yes, stress affects our she-motions. We can be, like I said before, high impact job, high impact life. That affects how we feel. You can have a stressful day at work and not even want to enjoy dinner with your friends and family later because your emotions are so affected by what happened earlier in the day. You can't quickly just switch back to being calm and happy and ready to face your friends and enjoy the pleasures of life. So our stress levels affect the way we feel. They affect our mood, and sometimes we can't get our moods back intact quickly than we like to. We can put on a strong face, and wearing our masks now because of COVID, it hides a lot of our facial expression. But some people were wearing masks before we had to wear masks. So we cry all night long, we say a prayer, we try to put on a happy face and put on a facade, and when your coworker says, "Hey, how you doing?" or your neighbor, "How you doing?" "I'm fine." We're not fine. We're holding everything that we've dealt with. We're not releasing it either because we don't know how or we don't trust to tell anyone. So we're holding our emotions in. That is affecting our body. That's affecting our heart, and that is affecting our mind. So her face looks stressed, and sometimes our face, we put a smile on or a look of confidence. Never let him see you sweat. But sometimes we need to sweat, and we need to see our sweat. We need to learn how to wipe the sweat and how to deal with it instead of just covering it. How can I improve my mental health as a woman? How can I improve it? How can I make it better? This is a personal thing. Like today, increasing your awareness of women's health, gaining knowledge. Knowledge is power. Somebody say, knowledge is my power. Knowledge is my superpower, and you don't have to read a whole bunch of books and memorize big words. I learned something today. I learned that when I'm angry, it affects my whole body. That's knowledge. I learned about serotonin levels. I learned that, PTSD affects women more than men. That's something that you learn that you can think about that'll help you. So any small nuggets or big nuggets of knowledge is a good way to bring awareness. That's a good way to improve your mental health is through knowledge. Having balance equals mental stability. Time delegating. Wow, this is a very interesting topic. So we have to delegate our time better. And I'm speaking to myself. I'm preaching to my own choir. We do a lot, and we sometimes think we can do more than what we should. Just because I can do it, should I do it? Do I need to say no? N-O, it's a full book, okay? No is a very powerful word. There's some things I don't need to do. I need to delegate my time better. I don't care if you need to get a notebook and write out the things you have to do for the day and put a time limit on it. I've put a timer on my phone when I've had a phone call from my own mother. Is she here? And my friends. How long am I going to talk to her? How much time am I going to give her today? You got to delegate your time. Okay, after 15 minutes, okay, I gotta go on with my day. Your time is so precious, you cannot get that back. So women, we got to delegate our time better. And it's not that you don't care about others, but you need to care about yourself. Redeeming my time, yes. Exercise and food intake changes. I did bold for that. I'm telling myself that too. So like I mentioned about getting the bowl of chocolate ice cream and sitting in the corner when you have a bad day, our mood, it affects how we eat and it affects our choices. When we're in a good mood, how many eat bad when you're in a good mood? I actually eat worse when I'm happy. Like I'm about to get a thing of lasagna and some breadsticks. When I'm happy, when we're in a celebratory time, graduation, marriage, you go to a birthday party, they don't serve healthy food. They serve food that makes you happy. Some people eat bad when they're feeling bad. It's comfort food. Somebody say comfort food. It brings me comfort. Every time I eat a chocolate chip cookie, my sorrows are melting away every time I swallow it. But it's a cliche, but it's true. Exercise and food intake changes improve our mental health. So maybe I need to monitor what I eat. Sometimes if I don't eat my 3 meals a day and my 3 snacks, I do become a diva like Aretha Franklin in the Snickers commercial. I have an attitude. Did you know that your mood is affected by whether you eat or not? Do we all eat 3 meals a day? Honestly. Because why? We ran out of time? Did we forget to make it? We just ran out of time. We're just gonna grab something on the way. Or I'm not hungry in the morning. I can't eat in the morning. It's a lot of reasons, but be surprised when you put something in your mouth, whether it's a peanut butter cracker, whether it's water, a piece of fruit, a granola bar, it helps your mood. I've been in situations where I was ready to snap or somebody said something and it ticked me off. And I'm like, wait a minute, did I eat? Did I eat today? Let me get myself together. Because we don't want to offend anybody. Us as emotional creatures, because they already expecting it anyway, right? No, you're not gonna get me today. I'm gonna eat something and prepare my body to work with my mind and my emotions to have a good and successful day. Self-care and self-love. This is a biggie for me. It's a lot. We've gotten a lot of information about self-care and self-love. That does affect our mental health. To share a personal story, when I got divorced, I had threw so much into my husband and into my children, I forgot who I was. So once I was divorced, I'm a survivor of domestic violence. Once I was divorced and I was able to be in a safe place, I had to figure out what I even liked anymore. What were my hobbies? What did I used to enjoy doing? And I had to tap back into that. So self-love and self-care, let me tell you, self-care is not just going to get your nails and your toes done. That's maintenance for me, okay? That's like going to get my car washed and my oil changed. It's maintenance. What is self-care? Taking a moment to try something new. Taking a moment to sit in silence. Going to a women's conference that I would never go to before. Joining a club, joining a virtual group. Trying something new, trying a new color. Taking a risk. Maybe getting a puppy or maybe volunteering to read at the nursing homes. Doing something outside of my norm, to care for myself and acknowledge the many different ways of who I am and how I can still be of use in this world to bring passion and energy to myself. So self-care is really self-empowerment. You know, getting your nails done is fun. Inviting someone to come with you, that actually can help you to be able to enjoy your life with someone and enjoy moments with someone. So self-love is that inner work, and that self-care is that outer work. So to conclude before we finish this, which I'm gonna need participation again, I want us to get the idea of approaching mental health the same way we approach medical and physical health. So the same way you make your appointment to go to the doctor, to get your teeth cleaned, to get your eyes checked, you having a pain in your stomach, you need to get a pelvic exam, you need to get an OB exam, you're a first-time mom, you're pregnant, you need to get a prenatal exam. I want us to take inventory and be aware that our mental health is just as important as our medical, physical health. It is so important, especially in this day and age. The COVID virus has affected our mental health in more ways than we even think. We have experienced trauma. We have experienced war-like symptoms with the death that we have experienced. It has affected us, each and every one of us, men and women, in our everyday lives. We have tried to survive and move on. It will never be the same, but our mental health can change for the better. So I want us, when we think about mental health, I want us to think about going to the laundromat or to the tailor to get our suits and dresses tailored to fit us. They do our neck measurements, our breast measurements, arm length. They don't really do the head measurement though, unless you're getting a hat. They do everything else but the head. I need to tailor and make adjustments to my mental health. I need to measure what has changed, what makes me excited, what makes me sad. What am I thinking about that's causing me joy, and what am I thinking about that's causing me pain? And for women, we have to be more in tune to how we feel. We have to be more in tune to how we feel and how it affects what comes out of our mouths and out of our hearts. The things that we see, the things that we hear, and the things that we say. We have to take better inventory of it. And I hope that if you get nothing else out of this presentation, you know that being a woman embodies so much, but our she emotions are very important. Our mood and the way we feel. Without that, we can't be the wonderful women, bearers, the holders, the helpers, the replenishers, and the wonderful women that we are to help everyone in this community. So I want everyone to repeat after every letter of every word, and I want to bring awareness to the word women. And after we say each letter, I'm going to read an adjective. If any of the adjectives speak to you in your life, I want you to lift your one finger up so that we can acknowledge and you can acknowledge the wonderful attributes of who you are. Are we ready? Okay, first, everybody just say women. Everyone say W. Worthiness. Wellness. Wisdom. Okay, mine is gonna be worthiness. I'm working on worthiness every day. I am worthy to be here. I'm worthy to be loved. I'm worthy to be healthy. I'm worthy to survive. I'm worthy. Everyone say O. Outlook. This is an important word, outlook. What is your outlook on life? How does your outlook look to you? Because only you know how you feel, and only you have the lenses to the eyes of life that you have to your heart and to your soul. So what does your outlook look like, and how does your mental health affect your future? Ownership. Everyone say ownership. We have to take ownership of us, our emotions, our past, our future, what we want, what we need. We can't blame everything on others, those of us who do. We have to take personal inventory of our own mental health. I said ownership of your health, mental stability, and ownership of our time. Remember that time delegation. Everyone say M. Makeup. What makes you you? What makes you the beautiful person that you are? You are unique. We have to hold fast to that. We are unique. And you know, we have good and bad attributes, but they make us who we are, and we should still celebrate that. E. Endurance. Essence. Endowment. I like the word endowment. It's different. I'm endowing myself with love, health, knowledge, good things, positivity. And I got to reach and grab for those things every day to make me a better person. Nurturing, necessary, needed. Women, we are the nurturers. We are the bearers. We are the ones that give life. We are the glue that holds things together. We are the women, we're the beings that hold things down. We are necessary. Society has shown us we are necessary. In today's world, we are very necessary. And we are needed. You are needed. We are needed. I am needed for myself. So I thank you for your time. And if you don't take anything else, we are women, we are strong, we are here, and our mental health matters.
Further questions for Ms. Halton? So I think you would agree to all of our panelists. Outstanding. Can we just give them another round of applause? Just outstanding. And so as my part of this comes to a close, I want to again thank 100 Black Men, Riverside Health System, and Hampton Roads Community Action Program today for collaborating to bring this forum to life. And I do want to thank my dear friend and colleague, Mr. Delvin Peaks, for extending this invitation to have me facilitate this event. But most of all, right now, just give yourselves a hand and thank you for being a wonderful audience. Wonderful. And so now we'll ask Mr. Bell to come back to give Mr. Bell, who's the president of 100 Black Men, give his closing remarks.
Okay. Thank you, Angela. And I want to thank our panelists today. I want to thank in advance all the folks who will be in the room, the testing room, and we are asking all of you to take full advantage of that opportunity in the Marion Poe room next door. A lot of testing will be going on, vaccines, et cetera. I know a lot of you are here for that. I believe our panelists will also be in that room, be they part of the testing or otherwise. So if you have some questions for them in that setting, please feel free to ask them. I'm sure they'll be happy to consult with you. But just a lot of thanks this morning. Again, you mentioned Delvin Peaks with Riverside. Riverside is instrumental in partnering with us to put on these health forums, so I really want to thank Delvin again and give him applause. This is the first time that we're partnering with Hampton Roads Community Action Program, and Matthew Alexander and his team have done a wonderful job of working to make things happen, so thank you, Matthew. I want to thank my members of the 100 Black Men that spread out in the crowd, and especially folks like Thad Holloman and Everett Browning and Joe Fernandez and others who have worked directly on this particular event. But I want to give applause to my men in the 100, please. Okay. Now, after the health fair, out in the hallway, there are lunches for everybody, just light lunch, but please take advantage of all the testing. This room is going to be transferred into a kind of a display room. There's going to be a lot of tables set up with information on various things, 100 Black Men, HR CAP, and their associated programs. So please take advantage of that. There also, when you're done, we have some surveys out front, and we really want you to fill out a survey. Give us some feedback on this particular event and help us, tell us how we did and help us plan future events as we go forward. Because, as we said, health and wellness is an important part of what we do, and we're going to continue in that initiative. Other than that, HR CAP had some giveaways, I believe, out in the hallway. Matthew, who's over there in the corner hiding, but he did a wonderful job there. He'll help orchestrate that. But there's some giveaways for folks, so please take advantage of that. And lastly, two other things. 100 Black Men, we're having our annual Black Tie Gala, our 29th annual Black Tie Gala on April 23rd, Saturday, April 23rd. And we're recognizing Dr. Bill Harvey, Sika Henry, who's the first Black professional female triathlete, and Riverside Health System. as honorees. We're recognizing our scholarship recipients. So there's some invitations on the table over there. If you're interested, feel free to take one. It's going to be at the Marriott. So that's a big event for us. The first time we're coming back together in person since COVID. And COVID is still upon us, so let's not forget let's not think it's over. But that's over there. And lastly, I'd like to say happy birthday to my father, who's in the audience. He's 82 years old today, Alonzo Bell Sr. And I'm pleased that he and my mom are here today with me, and I love you. Other than that, folks, we're dismissed. Please take advantage of the testing. The meals out there, and also, and again, in this room, there'll be displays. I believe our brother Julius Green, who's one of our members, will be at our table also. Julius Green was the second African-American Army diver in the United States of America, and he's written a book. Maybe an opportunity to talk to Brother Green, who's right here, and he's a treasure. So enjoy, folks. Thank you very much.